Just wanted to show another example of a patient with rectal carcinoma. This is a middle-aged lady, and this is a baseline study where you can see the tumor very close to the anus or the inferior rectum anorectal junction. You can see it as more like a polypoidal lesion, perhaps involving the wall. As you can, if I blow that up, you can see the mass here. You can see the high signal of the submucosa here, but then that seems to be breached here. I'm not too certain whether the sphincter is involved. It possibly is involved at this side, but that's not of interest. For the purposes of this discussion, this patient was treated with chemoradiation, and you can see in the follow-up study there was pretty decent response. You can see there is a scar. The scar is a little bit more substantial, a little nodular, but then there is also this area of high signal here. So this also had some punctate areas of high signal on diffusion, and so this would consider as near complete response or TRG1. Fast forward a few months, and this patient developed recurrence. As you can see, if I blow that up, you can still see some areas of scarring, which is that dark tissue, but you can also see that the mass is now much larger. So this is recurrence after chemoradiation when the patient is being surveilled, and the diffusion weighted sequences also show a similar kind of appearance, and you can see in the B800 here corresponding to that mass, you can see restricted diffusion. So now this, you have seen the complete evolution of a patient treated with with chemoradiation, who showed good response followed by recurrence. And in this recurrence, you can also see that the tumor is now involving the sphincters. When you see the coronals, it becomes a little bit more obvious.